Hello and welcome. My name is Tebo, and I am a professor of laboratory medicine and pathology in Mayo Clinic. I also co-direct the Antibody Immunology Laboratory at the Mayo Clinic in Rochester, Minnesota. I'm delighted you can join me for this brief presentation in which I will be discussing recent updates in the testing for anti-SSA Rho antibodies in systemic autoimmune rheumatic diseases. I will be particularly focusing on the clinical significance for the separate determination and reporting of antibodies to Rho 52 and Rho 60 in the evaluation of patients with this disorder. I have no disclosures for this presentation. The SSA Rho is part of the Rho-La heterogeneous antigenic complex, which is made up of 3 unique proteins: the 52 kilodalton Rho, the 60 kilodalton Rho, and the La proteins, as well as 4 small RNA particles, which is elegantly displayed in this figure here. Unlike antibodies to SSB La that are less common, reported separately, and mainly associated with the diagnosis of primary Sjogren syndrome, antibodies to Rho or SSA are most prevalent among many autoimmune diseases such as primary Sjogren syndrome, SLE, rheumatoid arthritis, systemic sclerosis, and inflammatory myopathies. Historically, Rho 52 and Rho 60 antibodies were considered as a uniform antibody system. Therefore, when Rho 52 or Rho 60 antibody is positive, the result is typically reported as anti-SSA Rho antibody. However, recent studies have provided evidence that Rho 60 and Rho 52 are not part of a stable macromolecular complex, and that these antibodies have separate clinical associations with implications for diagnosis, prognosis, and patient management. It is recognized that the Rho 50 and Rho 60 antigens are encoded by separate genes that are found in distinct cellular compartments. The significance of antibodies to these proteins in the pathogenesis of systemic autoimmune diseases are not fully defined. However, both proteins have potential roles in loss of immune tolerance, which is a breakpoint in the onset of many autoimmune diseases. Rho 52 is an interferon-inducible protein and can also be induced by viral infections or toll-like receptor engagement via type 1 interferon induction. It is therefore conceivable that it plays a role as a negative regulator for pro-inflammatory cytokine production. On the other hand, Rho 60 is a DNA-binding protein with protective functions against the development of autoimmune responses, as has been shown in some experimental model systems. Antibodies to SSA Rho is one of the 2016 ACR-EULAR classification criteria for primary Sjogren syndrome. Sjogren syndrome is one of the most common systemic autoimmune diseases, with a prevalence of about 0.6% and affects about 1 to 4 million Americans. As a secondary disease, it may occur with pre-existing connective tissue diseases such as SLE, rheumatoid arthritis, systemic sclerosis, or in the context of idiopathic inflammatory myositis, commonly referred as myositis, it may occur with one of the more specific markers for disease diagnosis. Of the 5 item domains in the classification criteria for primary Sjogren syndrome, the presence of SSA or Rho antibodies is the only clinical laboratory test with a weighted score of 3 as shown in this table. All others relate to the dysfunction of the exocrine glands. Therefore, appropriate testing and reporting of these antibodies is essential in the diagnosis of primary Sjogren syndrome. As shown on this slide, the clinical manifestations in systemic autoimmune diseases are commonly associated with antibodies to SSA Rho. Therefore, SSA Rho has been shown to have limited diagnostic utility in the evaluation of a number of systemic autoimmune diseases. Some of these clinical manifestations are shared amongst primary Sjogren's disease, SLE, and RA. Of diagnostic importance, the features of gastrointestinal, hematologic, renal, skin, and vasculitis, in addition to Raynaud's phenomenon, muscular and pulmonary manifestations are quite common in these disorders. As you would notice in this slide here, there is some plasticity of anti-Ro antibodies in the common systemic autoimmune rheumatic diseases. For example, although SSA antibodies is a classification criteria for primary Sjogren's syndrome, it is commonly found in patients with SLE and rheumatoid arthritis and many other autoimmune diseases. Therefore, given the overlapping clinical features associated with these disorders and the presence of SSA antibodies in these diseases, it is widely recognized that this autoantibody, if reported without distinguishing between the presence of Ro52 and Ro60, lacks diagnostic specificity. Although there is established evidence that Ro52 and Ro60 are different and have unique clinical attributes, which may allow for prognosis and stratification of patients, testing and reporting of these antibodies are yet to be harmonized. This figure clearly shows the different ways in which antibodies are being tested and reported in the clinical laboratories, not only in the United States, but worldwide. For example, some laboratories may test the Ro52 and Ro60 singly with solid phase assays or using multiplex assays, but report this as SSA positive in the traditional way. Alternatively, they can use a combination of analytes for Ro60 and Ro52 in single well testing, but reports the presence of these antibodies while and not differentiate which specificity is present. In another scenario, labs may report either Ro52 or Ro60 as being positive for SSA antibodies. And while the reporting of negative results are not largely impacted, stratification based on single positivity for Ro52 or single positivity for Ro60 or dual positivity for Ro52 and Ro60 is very important in patient evaluation and stratification. In an elegant study that was published in 2019 by a French group, they conducted a retrospective observational study which included every adult patient with positive anti-nuclear antibodies tested in their immunology laboratory, and that was associated with Ro52 and or Ro60 antibodies between 2011 and 2014. In all, they identified about 399 patients out of 1,300 patients with positive results for Ro52 and or Ro60 antibodies. The summary of their finding is shown in this figure and the table here. Based on their findings, single positivity of Ro52 was more common in the general population than when you have single positivity for Ro60 or dual positivity for Ro52 and Ro62. In the stratification of patients based on the presence of autoimmune diseases, combined positivity for Ro52 and Ro60 shows higher prevalence in autoimmune diseases than in non-autoimmune diseases, whereas single positivity for Ro52 was highly prevalent in the non-autoimmune diseases compared to patients with the other combination. Of diagnostic significance, for example, in the stratification of patients based on systemic lupus, primary Sjogren's, systemic sclerosis, inflammatory myositis, or inflammatory rheumatism, it was demonstrated that dual positivity for Ro60 and Ro52 versus single positivity for Ro52 was significantly associated with a diagnosis of systemic sclerosis, primary Sjogren's, inflammatory myopathies, and inflammatory rheumatism. In contrast, the presence of Rho60 versus combination of Rho52 and Rho60 was highly indicative of a diagnosis of Sjogren syndrome. This points to a significant role for separate detection and reporting of these antibodies, not only for the general population, but also in the stratification into specific rheumatic autoimmune disorders. In a subsequent study that was conducted in Belgium, these investigators expanded the repertoire of autoantibody tests to include the SSB-La antibodies, which is associated with Sjogren's, to further assess the role of Rho52 and Rho60 in the diagnosis and risk stratification of patients with primary Sjogren's syndrome. Overall, the principal component analysis of the data point to a stepwise model in which monoreactivity against Rho60 displayed the least objective and subjective glandular primary Sjogren syndrome features, whereas glandular abnormalities and signs of B-cell hyperactivity were most present in patients showing triple activity against Rho60, Rho50, and SSB-La. In this context, the authors suggested that separate determination of these antibodies is recommended in the context of primary Sjogren's diagnosis and disease phenotyping. In addition to the diagnostic and prognostic roles for the differential expression of Rho60 and Rho50 antibodies in primary Sjogren's, there are evidence for their relevance as prognostic markers for interstitial lung disease in patients with interstitial pneumonia with autoimmune features, generally referred to as EPAF, systemic sclerosis, SLE, and inflammatory myopathies. In the reference study presented here, the investigators sought to evaluate the probable role of anti-Rho52 antibodies, which coexist with anti-MDA5 or anti-Jo1 antibodies as risk indicators for inflammatory myositis that is associated with rapidly progressive interstitial lung disease, as well as predictors of inflammatory myositis associated with interstitial lung disease related survival in the Chinese patient cohort. In Figure A, the Kaplan-Meier curve demonstrated that survival was lower in patients with inflammatory myositis associated with interstitial lung disease who tested positive for anti-Rho antibodies than those without the antibodies. In Figure B, the survival was lower in patients with inflammatory myopathies who tested positive for both Rho52 and MDA5 antibodies than those with anti-MDA5 alone by log-rank test. All this suggests that when patients are diagnosed with myositis or at risk for myositis, the role of these Rho52 antibodies may have additional prognostic value in patient management. Beyond systemic autoimmune rheumatic diseases, the prevalence of Rho52 antibodies have been reported in a number of autoimmune liver diseases, and this association seems to have prognostic significance, especially when additional autoantibodies are present. In one early study dating back to 2007, patients with primary biliary cholangitis who tested positive for Rho52 and Sjogren antibodies were reported to be at increased risk for more advanced histological stage of disease. A similar role for the use of anti-Rho52 in disease prognosis was reported in autoimmune hepatitis when present with the soluble liver antibodies. In autoimmune hepatitis, therefore, both antibodies were shown to be independently associated with the development of cirrhosis, hepatic death, or liver transplantation. It does appear that in patients with autoimmune liver disease, testing for Rho52 would be implicated for disease prognosis. In a Mayo study, we compared the performance of two solid-phase immunoassays for the separate detection and reporting of anti-Rho52 antibodies in a consecutive cohort of patients undergoing evaluation for connective tissue disease. The multiplex bead assays and the chemiluminescent bead assays overall showed comparable performance when using the kit-specific cutoff for positivity. When the antibody positivity was stratified based on single or dual autoantibody positivity, we recognized that the positive correlation for row 52 was higher than for row 60 antibodies. However, overall, the positive agreement was acceptable with the higher correlation for row 52, as denoted by the kappa and the chi-square values. The lower correlation between the row 52 assays could be explained by how these antibodies are recognized or the prevalence of the specific connective tissue diseases in the cohort. Antibody reactivity to row 60 is largely dependent on conformational epitopes, whereas that for row 52 is dependent on linear epitopes. Further analysis are being done to determine the prevalence of these biomarkers in the different clinical subsets in this cohort. So who should be tested for anti-row 52 and anti-row 60 antibodies? To address this question, it's important to first indicate that with increased interest in early diagnosis and stratification of patients with autoimmune diseases, when these disease processes or burden may be modulated, delayed, or halted with target therapies, appropriate testing is very important. As a criterion laboratory test for primary Sjogren syndrome, row 52 and row 60 should be considered as first-line tests. Separate determination of row 52 and row 60 antibodies would also be recommended when suspicion of systemic autoimmune rheumatic disease is high. For example, in patients with overlap Sjogren syndrome, patients with SLE, systemic sclerosis, and inflammatory myopathies. In addition, both tests should be considered in the evaluation of autoimmune liver diseases, particularly when overlapping features of connective tissue disease is present, or in patients who have those diseases are at risk for systemic sclerosis or secondary Sjogren syndrome. With that background to who should be tested for anti-row 52 and row 60 antibodies, I would just like to use the last few minutes to talk about how should testing be done for these antibodies. Antibodies to row 52 and row 60 are associated with the nuclear antibody nuclear fine speckled pattern, which is generally referred to as AC4, using the HEP2 substrate by indirect immunofluorescent assay. Recently, row 60 antibodies have further been characterized as a variant of this AC4 type with distinctive myriad discrete nuclear speckles. Although the nuclear speckle pattern is associated with diverse analytes, testing for row 52 and row 60 is generally recommended due to their prevalence in autoimmune disease. It is also recognized that the ANA-IFA may be negative using certain substrates for testing anti-nuclear antibodies. And testing for row 52 and row 60 antibodies should be sought if suspicion for Sjogren syndrome is high. In Mayo Clinic laboratories, the SSA antibody testing is offered in several ways. This can be tested followed by a positive ANA by either the solid phase immunoassay or the HEP2 substrate for determining specific patterns. In the context of specific testing for SSA, there are several strategies by which clients can test for these autoantibodies. The SSA antibodies is included in the connective tissue cascade test, as well as it is offered in a multiplex bead assay in which there is no differentiation between the row 52 and row 60 antibodies. However, positive results from this system can be confirmed for row 52 or row 60 using a chemiluminescent-based assay, which offers separate detection and reporting of these autoantibodies. For this presentation, I've used a couple of references which are presented in the slide and can be used for further reference. Thank you for your time, and I'm happy that you could join me today for this presentation that highlights the importance of testing for Rho52 and Rho60 antibodies, not only for diagnosis, but for risk stratification for patients with connective tissue diseases and in some cases in autoimmune liver diseases. Thank you.